you. Can you guys hear me okay? A few years ago when I started going to mHealth conferences, they all tried to come up with a definition for what mHealth was, or a redefinition of it. And I think that made sense at the time, but now I think we've kind of moved past that. And mHealth has been now defined very broadly. So now if it's mobile and it's health related at all, it's really pretty much mHealth. So we're not going to try and define it here. What we're going to do though is show some examples of what mHealth can be and what's in that bucket, and just realize that there's a lot more out there that's not included in that bucket. What I do want to talk briefly about that I do think is interesting though is what potential value mHealth has and why people are so excited about it. So on the one hand, mHealth relies on the steady progression of technology that's been happening for years. Hardware gets faster and smaller over time, and software gets more and more advanced. So my cell phone is about 200 times more powerful than the PC I bought in college in the early 90s. And the software is far better, and it's networked in a way that didn't even exist back then. And that advancement in technology has allowed advanced computing power to spread all across the globe to pretty much every demographic group. And it hides in plain sight, masquerading as your cell phone or the internet. So that's been very easy for people. And at the same time, you have a healthcare system that's been struggling for a long time to find a way to provide care where it might have the most benefit long term. In other words, in patients' daily lives. As people have lived longer and generally safer lives, the impact of chronic disease on our society has become more and more pronounced. I think in the US now it accounts for about 75% of our healthcare spending is chronic disease care. And so the system is in desperate need of a way to manage that more effectively that works for the payers, the providers, and also the patients. So we're at kind of a unique time now where you have a technology that's kind of crossed this threshold and has become good enough and small enough that it can be mobilized and it can actually do it well. And you have a system that's in desperate need for a mobile solution to its problem. And I think that's why mHealth has become so exciting and why so many people are interested in it. There's a report about every week where someone's saying it's going to be some multi-billion-dollar industry by such and such year. So we all, those of us in the startup field, all are very eager for that to happen. So I'll get started. I'm going to introduce the speakers. Should I do it all at once or do it as you go? I'll do them all at once. So, and I wrote this out, so bear with me. So Dr. Aydogan Ozcan is an associate professor of engineering at UCLA. He'll be speaking first, where he leads the bio and Nano-Photonics lab in the electrical and bioengineering departments. He's received numerous awards and holds a number of patents for his work in near-field and on-chip imaging and telemedicine-based diagnostics. Dr. Ozcan will be speaking about new mobile phone-connected telemedicine technologies that he's been developing for general purpose microscopy, sensing, and diagnostics. After him will be Dr. Michael Miyamoto. He is a practicing cardiologist and medical technologist and is also the co-founder of uncleCare, a healthcare technology startup that is using mHealth tools to manage cardiac disease. Dr. Miyamoto is going to be discussing technology-enabled patient-centered disease management, specifically as related to cardiac care. And Susan Hall will be what's the term for that in a relay? I don't know. I don't remember. Is a nursing executive and is currently the Chief Health Informatics Officer at Diversinet Corporation, where she leads their mobile care coordination and clinical integration vision in product development as well as clinician and consumer decision support. She's also involved in several national organizations related to patient engagement and health IT. Susan will be speaking today about some of those national initiatives as they're focused on patient engagement and how mHealth is and can be involved. And I beg your forgiveness if I screwed up any of that. So without further ado, Aydogan Ozcan.
Thanks, Michael. It's a great pleasure to be here, and thanks for the invitation. So in this presentation, I'll go over the tool set that we've been developing at UCLA around the use of computation for bringing microscopy, sensing, and diagnostic tools connected to the cell phone or right at the back of a cell phone. And I think that's a very timely direction to explore because essentially our cell phones are getting more powerful every day. In this plot, I'm showing you essentially how the progress of the megapixel count of our cell phones, which are shown with these red dots, starting from 2002 up until last year, has been improving. Roughly speaking, it's been doubling every 2 years in its megapixel count. And it follows exactly the Moore's law, which refers to how our PCs have been getting better and better in terms of their transistor count. So this is quite surprising to me. That's why I want to start with this slide, meaning that our cell phones are getting quite advanced in terms of the optical components that we have at the back of our cameras on these cell phones. And that's fascinating because it enables us to do something very useful on the cell phone. In addition to this, in addition to the hardware, there's a massive volume that we can tap into, which is around 6.5 billion cell phone subscribers today, and most of them, more than 70%, are actually in developing countries. So you can tap into the cell phone as a platform that's very reliable, that has very advanced software and hardware capabilities, so that you can run advanced microanalysis, microscopy, sensing on the cell phone. And that's exactly the theme of our lab at UCLA, where we're trying to create new platforms for conducting telemedicine, whether it's installing a microscope at the back of a cell phone, as you see here, or in these other devices as I've shown here. Or if you do not want to modify your cell phone, we're talking about devices that are extremely lightweight and compact that can be used as a general purpose sensor, microscope, or even a diagnostic tool. So I'll tell you more about the tool set that we've been developing at UCLA over the last couple of years, tell some of the unique features of these gadgets. So without going into the details, these devices I refer to as Lucas. It's a platform technology that we've been maturing at UCLA. The key signature is that they are lens-free microscopes, meaning that bulky optical components like lenses or lasers or other bulky optical elements that you have in a regular microscope are eliminated entirely here. So we replace these bulky components that you normally find in a microscope with algorithms so that the entire device, entire microscope becomes extremely lightweight. This attachment to the cell phone is on the order of essentially 30-40 grams. And that gives us a phenomenal compactness, cost effectiveness, and at the same time throughput. These microscopes can look at very large areas with a very high sensitivity, and they are tolerant to misalignment. So there are some unique features of these microscopes that essentially use computation running on the cell phone or on a server to simplify the architecture of the design of these gadgets. And it has some other applications, not necessarily always for telemedicine, but using non-conventional images, you can look at extremely large areas. Now you're talking about something like 10, 20 centimeters square for finding maybe extremely rare events like circulating tumor cells using these microfluidic devices, or these kinds of technologies could be also useful for looking at extremely wide area micro-array imaging type of problems. So how does it work without the use of lenses? How can you see things that are at the micron scale, at a scale that is smaller than 1/1,000,000th of a meter? Essentially, because we do not have lenses in our designs, we are detecting the shadows of specimen. What is quite different between your own shadow and a cell's shadow is that we are opaque to light, and light cannot penetrate through us, so that's why your shadow is pitch dark. It doesn't contain anything useful. However, cells are very small, a couple of microns, maybe tens of microns at most, and that's why when they cast a shadow, they have a structure. So the shadows of the cells are like fingerprint in the sense that they contain these unique oscillatory features which can be treated as the signature of the cell. And you can do cytometric analysis like this, where you can look at whole blood and look at the shadows of the cells and count, for instance, red blood cells. These are all shadows of the red blood cells. And if you look closely, you'll be seeing other cell types which are white blood cells. So it could work as a cytometer to count the density of cells. But it's more than that, because these shadows actually contain holographic information of the cells, so you can reconstruct three-dimensional images of the cells as if you're looking through a microscope. And you can take something like this, which is essentially a bunch of cell shadows put together, it's whole blood, and reconstruct it using computer algorithms that are extremely fast, faster than 1,000th of a second, and create images of these blood cells from their shadows, which nicely match the conventional microscope as I show here, except there's no microscope there. Everything is based on a shadow imager, which utilizes computation to simplify the design of the microscope. So after this brief introduction, whether it's running on a cell phone, using the cell phone's camera unit, or a standalone design, or a benchtop design, depending on your needs for resolution, field of view, these microscopes work based on computational holography to reconstruct images of cells from their shadows. And you start with these shadows and quickly go back to the plane of the cell, and these are actually some white blood cells that show subcellular features. These are some platelets. And this is a general purpose microscope. You can look at blood, you can look at other bodily fluids, or you can look at your food or water to screen for instance, parasites. These are some Giardia parasites reconstructed from their holographic shadows. And these are some crypto waterborne parasites, which are again reconstructed, which provide a very nice contrast compared to a conventional microscope. A conventional microscope, we put these arrows, these orange arrows, to guide your eye, because the contrast of a conventional microscope, unless you do something special to it, is not as high as our microscopes, because these microscopes are essentially phase contrast because they're holographic. They have very nice a contrast for these small scale things. And you can combine the same platform with different kinds of biotechnology, microfluidic technologies. In this case, we're looking at, for instance, for HIV-positive patients, CD4 and CD8 lymphocyte counts, using spatial microfluidic devices which have surface chemistry on them to specifically and sensitively capture a subpopulation of white blood cells. In this case, CD4 and CD8 lymphocytes. And each one of these spots that you barely see here is an antibody island, and if you zoom in, you would be seeing the shadows reconstructed and counted. This way you can conduct essentially CD4, CD8 counts and have an indicator for antiretroviral therapy. Whatever I was showing you was essentially a simple microscope with a simple light emitting diode, a very, very simple light source here, extremely lightweight, on the order of, again, less than 50 grams in total. Now I'll tell you some tricks that you can essentially improve the resolution without sacrificing the field of view advantage. If you change your design a little bit, you make it complex, but essentially this is still extremely lightweight. This entire design is lighter than your iPhone, but it performs a very high throughput microscopic imaging of specimen. And it's still very inexpensive because the light sources, the components that we have in here, are essentially coming from digital electronics, and they're extremely inexpensive. To put something like this, which looks complicated, but essentially this would be less than $10 to put together because the components are, again, coming from digital electronics. It enables gigapixel microscopy, meaning that you can have billion or more than a billion pixels useful, giving you images of cells across a very large field of view, more than 20 millimeters square. So almost half a centimeter by half a centimeter, where there are a billion pixels there, looking at microscale things. Why do we care about this giant field of view? Because most often a pathologist would need to screen for rare events. In the case of, for instance, a pap smear or blood smear, you're looking at a monolayer of cells, and most often the rate of infection or the abnormal cell signature appears maybe 1% of the time. So you got to have, on this blood smear in this case, a conventional microscope scan a very large field of view with several hundred different images to screen for a negative sample, for instance. Whereas the same thing can be done very effectively with these computational microscopes. All the way from one part of the image to the other, you can create these images computationally, looking at something on the order of 20, 30 millimeters square field of view with deeply sub-micrometer resolution. And these are some malaria-infected cells that are normally imaged with a conventional microscope, and these are some computational microscope images acquired for the same cells, and these are actually parasites invading red blood cells. Of course, you can do this across a very large field of view, which is more than 2 orders of magnitude wider, and this circle here represents essentially the field of view of a conventional objective lens, conventional microscope. That's where the throughput advantage comes. And you can even see viruses with these gadgets. So essentially, I won't go into details, but you can see individual, in this case, H1N1 viruses, or in this case, another type of virus can be seen using the same technology across a very large field of view. This is essentially more than 2 orders of magnitude wider compared to the technologies that you can have for seeing these tiny things, which are around 100 to 200 nanometers. So some of these microscopes are bright field, as I've shown you, but essentially there are other kinds of microscopes that we have developed. For instance, this is a fluorescent microscope attached to the cell phone. This is a fluorescent cytometer attached to the cell phone. You load your specimen from the side, and this matchbox-looking add-on to the camera unit can convert this cell phone into a fluorescent microscope where you can look at fluorescent labeled parasites in this case, or white blood cells, Each one of them are captured by a cell phone camera. If you do not want to capture a static image, but look at a movie where we're flushing here some a couple of microliters of whole blood, you can actually capture a movie with the cell phone and count the cells as they're flowing. So it works exactly like an imaging flow cytometer, except implemented on a cell phone using a compact and cost-effective embodiment. And you can use the same device for capturing E. coli or other bacteria specifically. So this is essentially a very similar design, an attachment to the cell phone where these microcapillaries here capture specifically E. coli particles in water or milk, and they glow in red. They emit red photons that correlate to the density of contamination in your drinking water. This way you can detect something on the order of 5 to 10 colony-forming units per milliliter range using these inexpensive technologies. So some of these technologies actually have been already commercialized. They have been licensed by a startup company that I co-founded based in Los Angeles. Its name is Holomic, and Holomic has already acquired license for several of these patents coming from my lab. Actually, as of last July, there is a product out there which is a rapid diagnostic test reader attached to a cell phone. This is commercially available right now, which has generated lots of interest from especially U.S. Army and some other rapid diagnostic test manufacturers. Essentially, it's an attachment to the back of the cell phone where you insert your diagnostic test, and there's a smart application that runs, quantifies the rapid diagnostic test, image captured, and then creates a report of diagnosis, which then can be sent to the servers for final diagnostic reporting. With this, I'd like to conclude, and thank you very much.
All right, I wanted to thank the organizing committee for the invitation to speak, and to you all for your attention. I'm going to say a few words today about using mobile health technologies to attack the problem of heart disease management. So why focus on heart disease? As everyone knows, it's a condition that's very prevalent in the United States and the world. And above and beyond that, there are even more people with risk factors for heart disease, maybe without overt forms of heart disease, but are simply at risk for this. In the United States, almost 75 patients have hypertension, and the minority of these patients are actually effectively treated. There are observations that in the relevant demographic, there is a high and growing penetration of smartphone use. And so the combination of these observations suggests a very unique opportunity to positively impact the management of these conditions and lower the burden on the healthcare system in terms of costs as well as the medical costs. Actually, there has been a long tradition of mobile health technologies applied to heart diseases. So some of the Health 1.0 applications that have been in use for a relatively long period of time include devices like home blood pressure monitors, allowing patients to track, measure their blood pressure data, store it in the device, or in the case of some of the engineering type patients that I have present to the office with big spreadsheets of their blood pressure measurements. Paramedics responding to chest pain calls in the field have had the ability for a while now to record an EKG in the field and transmit that data to the emergency room, so that, for example, in this tracing, a pre-hospital diagnosis of a heart attack can be made, and the hospital can be prepared to treat the patient very expediently. So turning to some of the more present-day applications of mobile health technologies in this whole general field, we can start with a very broad population of patients concerned with wellness and fitness, and this probably includes the entire adult population of the U.S., but is an area that's rapidly growing that includes devices such as the Fitbit and the Jawbone Up devices, as well as apps to track activity levels, encourage exercise, and maybe some social media aspects of this, tracking your workouts, and also how you're doing in terms of your weight and other parameters. Then turning to patients with true diagnosed risk factors for heart disease, so not just the wellness and fitness population, but those patients with high blood pressure. There's no shortage of apps to track your measurements at home with or without being attached to some kind of device that can measure the blood pressure. Similarly, tracking blood sugars and your progress metabolically with diabetes apps and diabetes managers. Tracking other parameters such as your lipid profiles, cholesterol over time, obesity and weight management apps. So they're in each category, there are multiple solutions available for people to try. Smoking, quitting smoking apps, giving positive and negative reinforcement, and probably in the near future, incorporating genetic information into some of these solutions to maybe give a better sense of personalized risk. So that I think will be something we'll see very shortly. Then turning to patients with established heart disease, such as in this case, people who have, arrhythmias, coronary artery disease. You've probably all seen the Alivecor device, which is an ingenious device, which is basically has sensors mounted on an iPhone case that when contacted with fingers yields a single channel EKG tracing. And so this allows for detection and diagnosis, or the potential for this, in ambulatory settings. So you can be at home, you feel something, you pick up your iPhone, tracing is recorded, and these data then can be transmitted to a doctor or some other monitoring entity, and a diagnosis might be made. Then progressing on to patients with the most advanced forms of heart disease, as with congestive heart failure. The hope has always been that early detection of signs of clinical worsening can then set into motion interventions that might be effective in preventing expensive hospitalizations and rehospitalizations. So some of the the devices and technology that already exists include devices that are embedded within implanted pacemaker and defibrillator devices. And so here, algorithms use different bioimpedance techniques to detect fluid accumulation in the chest. And when heart failure patients decompensate, an early sign is often fluid retention, and this can be detected through these types of systems, and the information transmitted wirelessly to, again, some type of monitoring entity, whether it's a physician or an independent monitor. And so these signs of fluid accumulation can be detected early, and the idea is to intervene at this point before the patient kind of spirals downward, and therefore hopefully preventing a full-blown decompensation that might require a lot of additional care. Some devices that are in the pipeline are similar, but include direct left atrial pressure monitors. And so this is a device called the Heart Pod, which is being developed by St. Jude Medical. And it involves placement of a pressure transducer directly across the septum, or the wall between the two atria, allowing for pressure measurements in the left atrium through an implanted pacemaker-like device. This is considered by some to be the holy grail of monitoring in heart failure, and that is you can actually measure left atrial pressures in an individual patient depending on how they're doing and what else is going on in their cardiovascular system. So these are technologies that are being actively developed, and in conjunction with wireless systems and mobile systems may actually be effective in helping to extend accessibility to these types of data more broadly. So there are multiple potential benefits of applying mobile health technologies to the management of heart disease. We can clearly increase patient touches, so we can gain insights into how patients are doing above and beyond just seeing patients on a sporadic, intermittent basis in the office and in the hospital. The hope is that we can induce positive behavior modification by giving patients feedback, their data, as well as increasing their own insight into their own condition, their own risk factors, and hopefully therefore increasing patients' engagement in their own health. A lot of it is the accessibility of the information to patients in their mobile devices. Our hope again is that if we can extend the reach of these types of information and data gathering capabilities to wider portions of the population, we can intervene earlier and modify these risk factors at an earlier stage and prevent progression to more complex downstream phases of heart disease. With all of the data that are accumulated, I think there is a lot of potential for analytics and deriving clinical decision support capabilities that by looking at how people are treated in the past and the response to those treatments, then we can formulate ideas of how best to treat patients on an individual and a population basis. And this leads to active research opportunities. The UCSF Healthy Heart Initiative was just recently announced, and they're going to analyze patient data from thousands of patients using various sensors and app systems to, again, look at the experience of large populations and hopefully predict who is at highest risk and when for a significant cardiac event. An equal number of questions, though, are raised by mobile health technologies in this population, not the least of which is who is going to monitor the data, who's responsible for catching alerts that might appear in the data stream, what are the liability issues involved, who pays for this, and importantly, how are the data used? It's clear that at this point, the technology to measure data and to sense things in patients has developed ahead of the ability to integrate these into the processes of delivery of care. And so we can monitor a lot of things, collect a lot of data, but how actually this is going to be used to impact care delivery, that still, I think, needs to be worked out a lot more. There's a large potential for data overload. So you can imagine if you're a doctor and getting those left atrial pressure tracings from hundreds of patients every day, your first impulse might be to just turn off the monitor. So we need algorithms that can filter the data and really need to think about what is key data, what is extraneous, and really focus on the key types of information that we're interested in. A major problem is how best to foster positive behavior change using some of these apps and solutions. So we all too often assume that if we track data and record data, that will then translate into patients and providers doing the right things. But there's clearly a big jump that needs to be bridged on that, whether that involves ways of incentivizing patients, gamification, patient education. Those are all issues that need to be addressed. Passive versus active data monitors. The passive monitors are most effective in terms of reliability and requiring the least patient effort to collect data, but many of these are by their nature needing to be implantable or invasive. Active monitors might require more effort on the part of the patients, so they have to think of the trade-off of the type of information that can be gained and how active the patient needs to be involved in collecting that data, and then how to integrate these systems into existing clinical workflows will determine in large part how well they're going to be adopted by patients and providers. And so I'll close with this image. This is an image of a patient with calcification in the right coronary artery, the aortic arch, and the calcium in the aortic arch. This represents atherosclerosis. And the interesting feature about this patient is actually this patient's over 2,000 years old. This is an image from an ancient Egyptian mummy. And so it just reinforces the power of the human predisposition to these diseases. But I do think that applying modern mobile health technologies has great potential in improving our care of this ancient disease. Thank you.
Good morning, everyone. I'm pleased to be here and great to be third in the lineup. My remarks really, I think, build on the first two speakers in that I think we're at an incredible state change. And you know what Prigogine says about a state change. We try to work and work, and the system tries to recreate itself into what's needed, and eventually there's a significant state change. And as a nurse and executive and informaticist, I think we're really at a state change where consumers are going to be, I think, helping demand it as well as we as informaticists are really coming together, bringing these different disciplines together to really bring mobile health technologies, sensing technologies, sense-making technologies together in ways that can significantly contribute to lowering the cost curve. I've been in healthcare a long time, and one of the things I'm kind of excited about is actually lowering the cost of healthcare. And I think many of you too probably share a similar vision and have a belief in technology. But I think as we think about mobile technologies and being able to distribute them very broadly, we have a chance to do both healthcare surveillance, detection, things on a mass customization scale that we haven't been able to in the past. One of the things I've been particularly inspired with is the patient advocates in our community who are really not only demanding their damn data and wanting to be a partner in care, but I think they're really socializing us as healthcare providers to step up to recreate systems of care that are collaborative, that are meaningful, and that we start to nudge the consumer quotient of the care team even stronger. So I would say one of my key learnings has been there, and for those of us in IT, I think it's a very exciting time to listen to what they're doing. Ken Kaiser spoke about the Blue Button Initiative. I've been involved in this since its inception. And right now there are over about 460 organizations that have contributed to supporting this, about 68 organizations, vendors, others, payers who've committed by the end of this year to have Blue Button ready, which would mean 100 million US, of our citizens are going to have access to Blue Button data. And that's just in a very short time. And so one of the questions I would ask today is, are we prepared? Do we have systems in place to help that download of the Blue Button data and turn it into what Ken talked about this morning in terms of actionable, meaningful data that will really help in care coordination? As you know, the VA's effort to lead Blue Button has been really powerful. But in some ways, it's ready to also go to its next state change. There's a current RFP call right now to redesign the VA's Blue Button system. And part of it is because when the veteran downloads their Blue Button data, they get an ASCII file that they can print. And so, in some ways, one concern is consumers are going to push us even more once they discover how many data silos we actually have. And I think they're expecting that we're connecting it all up. And the transparency of some of this download and exchange of data from consumers, I think, is coming to an interesting place. One of the things that's been helpful, and you've probably seen it last December, the NEHIT group put out a roadmap to consumer e-health. And at first blush, it looks like consumer engagement, mobile technology, and other ways. But it's a roadmap for informing me, engaging me, empowering me, partnering with me, support my community. But what's interesting, it's not a linear roadmap. As Ken Kaiser talked about, the complex adaptive system, we already are seeing innovations percolating in all levels of this roadmap. And the tools are actually available now. So I like what I think Michael said. The tools are actually ahead of us as informaticists to really begin integrating them into our workflow and our tools. But this is a great roadmap to just check where we are as informaticists, whether we're vendors, whether we're providers, whether we're payers, whether we're health exchanges. How are we actually really engaging consumers and pushing the edge on some of the tool development? I've had a chance just recently to be appointed to the Health and Human Services ONC committee or work group on consumer technology and standards. And of course, as much work as we've done in the informatics community on interoperability and standards in connecting provider data, we now have another hurdle to connect consumer-based and patient-generated data. and really assure that it's interoperable. So the two new work groups that have been formed, one is on consumer empowerment in technology, the other is consumer standards in technology. The priorities are data portability and shared care plans. So it's an exciting time to be innovating in this space, and as you can imagine, we can't innovate in this space without mobile health and mobile technology. One of the efforts that I've been involved in and I'd like to invite you into, and you may already be considering it in your own organizations, is what are we going to do with patient-generated health data? How are we going to bring meaningful patient-generated data into our EMR systems to bridge the gap of what we've collected as providers to get that more social determinant of health kind of information with a meaningful profile, with health behaviors. An effort was, actually this was published in the summer issue of JMIA, a multi-stakeholder effort with about 30 organizations to look at if we could standardize a minimum data set and make it interoperable for patient-generated data, what would that be? Well, I'm now working with other colleagues to take this in the mobile world. And what if we could, across all the mobile app developers, start with some standards and interoperability, even at the core set, so that as we define sleeping patterns, we're not defining it in many, many ways. So if anyone would like to chat with me about that, I'd love to engage you in some of the work that's being done. This particular work has had 18 pilots done in a variety of care settings, a variety of populations, and I think it's a great start. And so there's really a future roadmap for taking this forward. The other thing is that when we start to look at shared care plans, as you know, I'm a nurse, care plans have been a bugaboo our whole existence. And as we think about having care plans that are meaningful for the patient and the provider, say 48 hours after discharge, the first 30 days, or just chronic ill care plans, how do we have them be dynamic, portable, and how do we share data in and out of these variety of systems that we are now working with and make it sense. And I think as we add the sensor feedback, if you think about it, when we're looking at a care plan, how do we know the patient has adhered? How do we know that they're actually getting to the outcomes we've hoped they would and prescribed in a care plan? So the sensing data, the biometric data, the feedback loops that we can get through telemedicine, mobile health, brings a new avenue to making shared care plans actually work. We can also use, of course, questionnaires, surveys, anything we can push out with mobile technology. But if we can bring that back together to start making sense of what we're prescribing and its efficacy, I think we've got some interesting opportunity. I've been working with a project called a mobile health wallet, a virtual health wallet, where we're trying to blend these things together in terms of consumers being able to store, exchange, manage their health data in a portable mobile personal health record, to have preferences that give meaningful information to providers about my social determinants of health, my preferences, my lifestyle, to have a shared care planning process that's dynamic and can work with various members of my care team that will change dynamically over time, and then secure communications that can allow for the privacy and sensitivity needed around my health information that's very granular, particularly around mental health issues, around HIV, around substance abuse. I think I like Mike's closing. He's already actually asked some of these questions. We're in a place where we're evolving the science, and we really have an opportunity to begin using our big data and analytics to help us learn how this engagement works and what kind of outcomes we're actually getting. I think the sense making, when we start adding place-based data, oh good, I turned my alarm on, my time's up. I'm on my last slide. I just make sure I need to turn the alarm off. When we start adding place-based data to this sensing data and patient-generated data, I think we have a lot. And then finally, I just encourage you to stay involved. As you know, the mobile HIMSS website has a lot. There's also some cool stuff at the HHS-ONC. Thank you. think my time's up.
Yeah.